Hi there, everyone. I'm doing another Facebook Live Dermpath rounds today for everyone, and I hope you're able to join us. If we haven't met before, my name is Dr. Karen Trainer, and I am the founder of Innovative Vet Path, and I have put together some interesting cases that we've had recently that I'd like to share with all of you. And we'll go ahead and get started. Hopefully the technology will be working this time. I'm going to try, I think I figured out how to monitor comments and whatnot as we go, so hopefully that can work. But if not, I ask you to please bear with me and I will follow up with them afterwards. So let's see if we can get this show on the road. All right, so we're going to dive in with our first case, and I hope there might be a little bit of a delay, but I hope that you're able to see this. So our first case here, this is from a 6-year-old female spayed dog. She is an Italian Greyhound, and I will tell you that she was treated for IMHA, which is immune-mediated hemolytic anemia, and she was treated with 2 milligrams, 2 mg per kg of prednisolone and 50 milligrams of cyclosporin twice daily. And so this dog had presented with lesions over the dorsal right pinna towards the base. There was a 3 millimeter raised papule. She had lesions, pitting edema over the left hind limb, scattered raised intradermal pustules that started emerging over the lateral proximal limbs. She also had numerous lesions. I'm actually going to show you the clinical photos. So I'm going to show these photos to you while I'm sharing the history so that you can see them. So I'm hoping that this is working. Here are the photos. This is Luna. She has some pitting edema here on the hind limb. She has intradermal pustules that are starting to crop up all over her body, some areas of erythema. And I apologize, it's a bit out of focus, but this is sort of a pustule that's starting to develop on her skin. And from what I was told is that this dog had presented to the emergency service and that the lesions were erupting, and even she started developing subcutaneous nodules, and that they were erupting and developing very quickly. So these were, they collected biopsies and they submitted them to me overnight FedEx as a stat case. We don't get a whole lot of stat cases on Dermpath services that I've worked on over the years. But this was a stat case, and the dog was starting to develop these cutaneous lesions, were erupting all over her body, and they acted very quickly. They took excellent biopsies. They also submitted for culture. But we'll take a look at some of these biopsies and we'll go through and see what we find here. So these are sections of haired skin. And you can tell that they're very busy. There's a lot going on here. So lots of blue. We can see, just to get oriented here at low power, we have the geniculus, the adipose tissue, and then we have our upper layers here. We have the epidermis, the dermis, and we're looking at sections here of haired skin. And I've got a couple of slides that are H&E, and then I have some special stains that I'll show you as well. So we can tell that there is a lot of inflammation. There is a lot of blue just at this low power. We see it infiltrating all the way from the surface all the way extending through the dermis and then down into the subcutis. So we have a pretty uncontained inflammatory process. So we've got a lot of inflammation here. And then what we're looking at here is a blood vessel within the adipose tissue. So when we take a closer look, we can't really get a clear picture of where the endothelium is because there is some necrosis within this. There's accumulations of fibrin, hemorrhage, some various inflammatory cells. So let's take a look at what types of inflammatory cells are in this mix. We've got loads and loads of neutrophils, and we've got a lot of, we've got some macrophages mixed in. We've got some couple of multinucleated giant cells, maybe fewer lymphocytes and plasma cells. One of the differentials they were concerned about for this dog was a sterile inflammatory process. If I recall correctly, they had done skin cytology of the nodule and found too numerous to count. I'm reading from the history now. Pyogranulomatous inflammation and no infectious organisms seen. So they were thinking perhaps a sterile inflammatory process. And I would have to agree that would certainly be on my list of differentials for this. But there's a few things that don't seem quite right. And so we'll walk through those so you can see that as well, I hope. So like I pointed out, the other lesion, there was some vasculitis and thrombosis, and we see that again here in the panniculus embedded within all of this inflammation. And so this is not a change. The vasculitis, the thrombosis, hemorrhage like this, it's very explosive, very dramatic looking inflammation. This isn't something that I see terribly often with sterile inflammatory processes. Certainly they can be absolutely very destructive. Things like sterile nodular panniculitis can cause dogs to have fever or systemic signs of illness. They can be lethargic. But if you see this, like just looking at low mag here, this is an extremely powerfully destructive inflammatory lesion. The dermis is being lifted off, and then there's just this massive accumulation of inflammatory cells lifting away. And then large areas of necrosis surrounding these hair follicles. And this is far more destructive. And then again, we have thrombosis of blood vessels. So here we can appreciate some of the endothelial cells. And those are the cells that line the blood vessels. And we see some over here, but the lumen has been replaced by fibrin. So that's fibrin thrombi. And then there's necrosis all around it because now this tissue immediately surrounding the vessels is being starved of oxygen. And we have erythrocytes and leukocytes and fibrin spilling and pouring and oozing out of these vessels in very dramatic fashion. And again, we have another vessel here, which is looking very poorly. These endothelial cells are swollen, they're plump. You can't clearly see the vessel wall any longer. It's very hard to appreciate. So this is far more destructive than I would expect for something along the lines of sterile pyogranuloma syndrome or sterile nodular panniculitis. Now, both sterile nodular panniculitis and sterile granuloma pyogranuloma syndrome can affect the dermis and panniculus. So with SNP, with the panniculitis, the lesions start deep and can come more superficial. And then that's where you get those big nodular, oozing, draining tracts that you'll see that can be very dramatic. And then with sterile granuloma, pyogranuloma syndrome, the lesions tend to start out more in the dermis and can run can run deeper and involve the pedunculus as well. So sometimes they can be a little bit hard to tell apart based on histopath alone, which is why I really appreciate when I get great clinical history and clinical information, clinical photos. Dachshunds in particular are especially prone to developing SMP with paniculitis. So sometimes having that breed information is helpful. But what also struck me, so the level of destructiveness of this lesion seemed very out of character for these sterile types of inflammatory lesions. I was cruising around, so looking for something like dermatophytosis, would that be causing this? And I was not seeing any evidence of dermatophytes in the hair follicles. And this doesn't particularly seem to be focused on the hair follicles. It doesn't necessarily seem to be folliculocentric. Certainly in some of these sections, there is evidence of furunculosis where the follicles are being blown apart and the normal architecture is being destroyed, but that doesn't seem to be the primary focus of this inflammation. The other thing that struck me as very odd for a lesion of sterile nodular paniculitis or sterile granuloma pyogranuloma syndrome was the fact that this dog had the history, which I'm so grateful to the clinician for including, but that history about being on prednisone and cyclosporin. Those are normally very effective for treatment of sterile inflammatory processes. So why would this dog all of a sudden develop these lesions when it is being immunosuppressed? So then I will tell you this was on a Friday when the slides were received at the lab. And so I drove over Friday evening to pick up the slides after I put my daughter to bed. My husband was looking after her, so she was okay. I drove over to the lab to pick up the slides. This was in the evening, and I was, it was and Friday night. But I was thinking, something about this doesn't seem right. So I just kept looking and looking, and I'm going to try and show you what I finally stumbled across that helped me to solve this case. So as I was cruising around, I ended up finding some areas that had our answer. So we do have two slides. I'm going to switch over and see if it's on the other one. So I did end up finding what we were looking for. I do always encourage, cytology is an excellent starting point to start from on these lesions. And here we do have some evidence of furunculosis. We've got the epithelial lining, possibly even of some sort of cyst that had broken open. So we do have that here. I am going to go back to our other slide because I think that's where our primary lesion is. And so what we've got is all of this inflammation. And then as I was going around, I'm going to try and find it. But so if we take a closer look and we just get up closer, I was able to find some areas of bacteria. And it's because I'm on a Facebook Live, it's harder to find. But I promise you it's there and I will find it. So we're going to show it to you. And if I can't find it on the scanned images, I'll show you on the still images that I took. So let's take a look in here. Okay, I think, all right. So I'm going to switch over because I've been talking this up. Let's see. Let's just take another look here. I don't know why this isn't cooperating. All right. So we're just going to zoom in and we'll look around and we'll find it together. So just taking a closer look at this inflammation. Again, like as we talked about, they said they found tons of hyogranulomatous inflammation. Certainly we can see that, but what's interesting to note here as well is that there's a lot of this streaming material. So some of this is fibrin and some of this is from degenerate neutrophils. So when neutrophils are activated, particularly when they are fighting infectious processes like bacteria, they will release their chromatin from the nucleus, and that's called a NET. NET is the abbreviation, and this is a really interesting process where they'll actually sacrifice themselves as a cell, and in the process of degenerating, they release the chromatin out into the environment around them. And they use the chromatin as a net, as like a lasso, to capture whatever the infectious agent is and capture it and contain it so that it can then be taken up by other neutrophils that are in the area before they reach that point, or by macrophages. So that's part of what we're seeing here as we're taking this closer look. When you see that streaming nuclear material, which I'm sure you guys have all seen when you've done cytologies, when you see all those strands of chromatin everywhere, those are the nets. And there's a really amazing video that I saw years ago, back when I was studying for the big quiz in pathology. I think it was during my residency, when I first learned about these. And I think it was a publication on Science. Here we go. And they showed the neutrophils, amazing microscopy video, and they showed the neutrophils with the chromatin as they were as the cells were degrading, and then releasing the chromatin out into the environment around the neutrophil to capture and entrap the bacteria. It was really an amazing video, and I encourage you to look it up. If I find it, I'll link to it below and in the group. But this is what I ended up finding after quite a bit of searching in these slides. Even though I know the diagnosis, it's still hard to find. So I'm not surprised that when they did the cytology that they didn't have infectious organisms. So what we have here, what we're looking at, is a colony of bacteria. And this is staining sort of amphiphilic, almost a little bit basophilic. And we can see it's this cluster, it's this ball of organisms, these bacteria, and it's radiating all around. Reminiscent a little bit of Splendori Hopley, or Hopley, I'm not even 100% sure how you pronounce it, I always read it. So we have that colony right there. And then I felt more confident going forward that we've got a diagnosis. And here's the other spot. Okay, here, now we're in business. So now we zoom in and we've got another conglomerate of bacteria here. So I called the clinician. This dog was admitted to the emergency service because it was devolving so quickly, and the cutaneous lesions and subcutaneous lesions were erupting so fast. So this dog was in very poor shape. So I called and I got one of the emergency ECC residents. And I spoke with her on the phone. She said, "Oh, yes, I've got the dog here." I asked a little bit more about her history, and I said, you know, my best guess, my top two differentials for this, I think I found bacteria, and my top two differentials are Nocardiosis or actinomyces, based on the history of this dog being on immunosuppressive therapy and then how quickly these lesions erupted. She's like, "Oh, I'm studying about nocardia and nocardiosis for my board." So she's like, "I'm reading about that right now." I'm like, "Well, I think you've got a case in the clinic." So I said, you know, I'm going to do special stains. There was not a whole lot of that that I could do about that on a Friday night. So I said, probably be out on Monday. But fortunately, the clinicians did a fabulous job ahead of time, and they submitted samples for culture, and they did get culture back that confirmed the diagnosis of nocardia. And I'm going to show you, again, I'm going to switch over, and I'm hoping that this works. So this is where we left off. And so this is a gram stain. Now for nocardia, they will be somewhat gram positive. That's why you're seeing this sort of bluish appearance. With gram negative, they'll appear red. I will keep to myself how I remember positive versus negative staining. So with nocardia, they will be gram positive. And so you can see that there's sort of this filamentous, almost beaded type appearance, which shows up much better with the gram stain than we were seeing on H&E, because the organisms do not show up well on H&E. But you can see them embedded in the inflammation, not just in a cluster or a colony like we saw in those two spots on the other slide. And so again, we see the bacteria is more visible when we use the gram stain. It highlights it so much better than when we're hunting around with the H&E. And this was, again, one of those things where it's delightful when you're the pathologist, but of course frustrating for the clinician or the pet. And I understand that, but it's good that it gets us to the answer, and it tells us, okay, we have a plan now to go forward and treat this effectively. And so then with the gram stain, it'll be positive, and with acid fast, it will be weakly acid fast positive. And that's how you differentiate nocardia from actinomyces. Actinomyces will not be acid fast or partially acid fast. So that's what I'm trying to show here. And then I did find some articles, which is what I was looking up that night when I was reading out this case, and I did find that other people have confirmed this in other dogs. So they have found disseminated nocardiosis in dogs, particularly when they were immunosuppressed or being treated with cyclosporin. So I thought that was a really interesting case, and I thought it was very interesting. This is another case report. This one, I think, came out of Australia. This dog was also treated with cyclosporin, and this was a couple of cases. I think this was from vet dermatology, and this was in 2 dogs that were treated with cyclosporin. So I thought this was very interesting, and that'll be our next case. And I just wanted to share with all of you, because I had not seen this particular presentation before, and it was so interesting, and it was very well worked up. All right, so going back to our slides, and I really do hope that all of this is working. So I'm going to go back and pull up our next case, and that one is just a case that I think I saw just either, I can't even remember now if it was last week or earlier this week. That's, I guess, what time of COVID is doing to us. So just to let you know, this is from a dog. She's a 5-year-old dog, or male, it's male, neutered male dog, and this is from a wire-haired pointing griffon. And so if we're looking at low MAB, you can try and guess where these biopsies are taken from. So not really seeing any hair follicles, a couple of adnexal structures, a couple of hair follicles here. So we're at the junction of haired and non-haired skin, but particularly what type of non-haired skin are we dealing with? And for the pathologists and dermatologists that are familiar with Dermpath, you will recognize this as being the paw pad. We've got the very thickened stratum corneum, and then we have the eccrine glands here that are embedded and associated with the adipocytes, adipose tissue, and these are a modified type of apocrine gland. And these are the sweat glands associated in the paw pad. But this dog, she had, or he's had, I'm sorry, I keep saying she, had a history of lesions that would appear only on the paw pads. This dog did not have any other systemic signs of illness. And he had lesions that had a waxing and waning appearance, and it was only involving the paw pad. And there was some splitting and peeling, which should already start to give you some ideas. But when we're looking at paw pad lesions, and if it's only the paw pad affected, certainly conditions like pemphigus foliaceus can affect the paw pads. In particular, you have lesions like idiopathic nasal and digital hyperkeratosis that can affect either just the nose or the paw pads or both. So those are some differentials. Perhaps zinc responsive dermatosis might be something to think about. I know last week we had that really interesting case of junctional epidermolysis bullosa. And we do see something abnormal here in the epidermis. That's really where the action is. So let's take a closer look at that. As we're looking here, there's not a whole lot in the way of inflammation. So that helps us to rule out something like pemphigus foliaceus, where we would expect to see some subcorneal, sometimes intraepidermal pustules, and perhaps some serocellular crusting. We would expect to see acantholytic keratinocytes with that, those rounded up cells, those shrunken, rounded up, brightly eosinophilic cells. And we're not seeing any of that here. But what we are seeing is again, a cleft. So we know this cleft is real rather than simply artifact, because we do have accumulations of hemorrhage and fibrin within the cleft area. And then there is a lot of hemorrhage on the surface as well. Sometimes this is just artifact with biopsies, but I suspect it to be real in this case as well. But we have very little inflammation here in the dermis. We do not have significant parakeratosis. If we're looking at the stratum corneum here, this is mostly, it's densely compacted in these areas, but it's there's no nuclei. So it's orthokeratotic rather than parakeratotic. And then what is also very different here, so that helps us to rule out if we have the absence of parakeratosis, that helps us take zinc responsive keratosis, dermatosis off of our list, and that helps us to take off hepatocutaneous syndrome because this dog has no systemic signs of illness. So we don't have cause to suspect any sort of, say, vacuolar hepatopathy with this dog. Only the paw pads, waxing and waning lesions, a sort of young, perhaps middle-aged dog, and a somewhat active breed, wired-haired pointing griffon. And so what is really abnormal here is that the keratin has a slightly different appearance than normal. And it's concentrated primarily where this cleft is happening. We have loss of the uppermost portion of the stratum corneum is being lifted off here. And what we see at the edges is how brightly eosinophilic the stratum corneum is and these other underlying layers of the epidermis. And this is where our hemorrhage is accumulating. So we have this brightly eosinophilic looks and this is something that you see. I don't know about, where different folks were trained. I remember in vet school, made a strong impression on me. One of the pathologists said, red is dead. On histopath, when you look at a slide and you see something that's brightly eosinophilic, that's not normally, that's often a clue to think, red is dead, it's necrotic tissue. So what we have here is necrosis of the stratum corneum, necrosis of the upper portions of the epidermis. When we look here at the basal layers and the granular layers, this portion here, the stratum granulosum, is affected as well. It's more eosinophilic. And then we have the lower portions, though, really don't look that bad. We don't see any interface pattern. There is a touch of inflammation, perhaps around a few vessels, but we can't quite clearly identify what those cell types are, or what the pattern is. So we have this necrosis in the upper layers, and this is called split paw pad disease. This is a somewhat controversial diagnosis. Some wonder how real this is. There's not a whole lot in the literature about this. And so I thought this was a really interesting case to share with you guys, but the staining properties of the stratum corneum just appear different, and it's described as having a coagulated or cooked appearance to it. And so I'll show you some other photos that I took from the slides. We'll go through those. And so these are just what I took off of the scope, and you can see here just how brightly eosinophilic the keratin is. And that's where it's all necrotic, and how that split is dissecting through the upper layers of the stratum corneum and the epidermis. I optimized the contrast on this so it's a little bright, but you can just see the difference in the staining property and how necrotic it is, and versus over here where it's a little bit more normal, we don't have that abnormally eosinophilic appearance to the epidermis. And this is just showing that cleft again. And this is where the upper portions just shear right off. And this is the dog. And there's not a whole lot out there about this condition. I've only seen maybe 14, 15 cases of this or so. And so I just thought it was interesting and would be fun to share. I don't know if there's a whole lot in the way of treatment for this condition. There is some thought that maybe protective booties, but that's something that I would really defer to clinical folks about. And then I did want to share with you some follow-up pictures, since I was having some technical issues last week for rounds. This is from the dog that had the lymphoplasmacytic pododermatitis. So here she is, and here are some lesions from, this is how the paw looked initially when the biopsies were collected. You can see the paw pad is swollen. And then this is some follow-up pictures almost 2 weeks after treatment was started. And she's been on doxycycline, and you can see that it's a little bit blurry, but all those ulcerated areas, like from here, have started to re-epithelialize, and it's starting to heal, and it's looking so much better. And I just wanted to share that with you because getting the right diagnosis, this dog had had a lesion on her paw since August of 2019, and finally getting biopsies and pictures and sending it to a Dermpath and getting all of that tied together, getting the right diagnosis, getting her on the right treatment with doxycycline. Finally, she's got some resolution, and she's well on her way to recovery. So I just wanted to share those with you, and I hope you've enjoyed this. If you have any feedback or suggestions or recommendations, I'm happy to hear them. And I look forward to seeing you next time. All right, take care. Bye.